So what we'll be looking at and going through today is why are modes so difficult to understand, looking at some of the nomenclature, look at what makes up a mode, and we'll be examining the three most commonly used modes of ventilation on the Paediatric Intensive Care Unit at King's. So why is understanding modes so difficult? Well, largely because if you ask any of the practicing intensivists what the best mode is for any particular child in any particular situation, they promptly stick their head up their opinion, which may or may not be the most current thinking. But the reason that happens is that ventilators are actually very, very technical and not necessarily that easy to understand in the first place. The concepts we're trying to get across are actually quite abstract, and manufacturers don't necessarily give you the best help by naming things in a certain way. On top of all that, clearly we have many other things to do and get a grasp of. So with ventilation, we're trying to marry physics with clinical medicine, which clearly both of them are actually quite difficult on their own. So combining them makes it that much more challenging. So if we look at the nomenclature and what we get from the manufacturers, the problem is that they want to sell ventilators, and because of that they want to brand them and tell us what their unique selling points are, and in doing that they've designed this system where if one ventilator comes up with a name, no other company can use that same name. So it's actually quite tricky. So you end up in the situation where exactly the same mode of ventilation will have various different names. So here's 7 or 8 different companies which have a mode of ventilation. So this is, in this example, is volume controlled ventilation, and you can see a whole array of different names, and those names can even change within the same company. So here you have Draeger, and they have volume controlled ventilation as IPPV, IPPV assist, and VC-SIMV. So it's not surprising that people entering intensive care for the first time are immediately confused, especially if they've come from a different unit which use a different company to supply their ventilators. So I'll try and unpick some of the intricacy within the nomenclature. Well, we start with volume. So volume is usually a target. So if you set a volume, you're setting the volume, but the ventilator will deliver that volume via continuous flow breath. Now, I have described this before in one of my previous videos, and I can't really go into detail of that here because that would just make this video way too long. Pressure obviously is a target, and we often set pressure, but pressure is delivered by a decelerating flow breath. So if you see volume or pressure within the name, usually that would be the target. So control or mandatory usually means that this is a mode where the ventilator is in charge and that breaths will be given by the ventilator. Sometimes, especially if you see mandatory in the name, you can see things like synchronous in there as well. But this means that the ventilator will give some breaths, and if they're synchronous with it, the patient is also able to trigger breaths. Spontaneous usually means that the patient has exclusive right to trigger breaths, and that the ventilator won't get involved unless there's a problem. So if the patient stops breathing, you'll either get a backup rate with a lot of the neonatal ventilators or some form of apnea ventilation in the ventilators that we use on the pediatric unit. Assist control, where you see this in the mode, it usually means that the patient will get breaths which are generated by the ventilator, but if the patient triggers a breath, he will get the exact same breath as the vent was given him previously. Those of you that use SIMV BiPAP or SIMV volume, where we have pressure support, will know that that isn't how they work. So for the assist control type of modes, you will always get the same type of breath, whether it's ventilator or patient triggered. Whereas in the synchronous sorts of modes, the patient is able to trigger some of the mandatory breaths. So if you set a rate of 30, the patient can trigger some of those, and some of those can be given by the ventilator. Usually the synchronous modes will also add pressure support. So therefore, if the patient tries to take a breath outside the mandatory breaths that have been set, he'll get a pressure supported breath. So in assist control, you always get the same breath. In the synchronous modes, you can get a variety of breaths. So some of them will be ventilator generated, some will be patient generated, and some of them will be patient generated pressure support breaths. Time cycling refers to how expiration is initiated. So usually you set an I time. At the end of the I time, the ventilator automatically cycles to expiration. Flow cycled usually means that the patient or characteristics within the patient's thorax and chest can initiate expiration. So if the flow rate drops to a certain level, then expiration can commence irrespective of the I time that has been set. So I hope that wasn't all too complicated. So which mode do you start with when you actually want to ventilate a patient? Well, you need to ask yourself certain questions. The first question you need to ask yourself is, what type of lung am I attempting to ventilate? So is it a normal lung? Is it sort of like a very stiff ARDS kind of lung? Does the patient have asthma, bronchiolitis, or is it a mixed picture? And based on that, you'll know the sort of settings you would need to commence. You'd also need to ask whether or not there's a disease-related strategy that you ought to follow. So what you do for a head-injured patient is different from a patient with pulmonary hypertension or cardiac dysfunction. So you need to take that into consideration. You're also going to need to ask yourself, how are you going to protect the lungs from ventilator-related injury? And are there any modes that help with that? So are you going to use things like permissive hypercapnia and permissive hypoxia? And does the mode or the settings within the mode help with that? And also you need to ask yourself what contribution you're expecting from the patient. So if it's a patient you're not expecting to breathe, a control mode would be fine. Most of the time we want some contribution from the patient, and therefore we tend to go for the synchronous modes. Whereas if we've got a patient that's we're hoping to extubate quite frequently, they would go to some sort of spontaneous mode. Now, the thing about this is that nobody agrees. There's very little evidence, and where there's no evidence, we search for consensus. So this is SPN-CPAP looking for consensus, where they spoke to some quite august colleagues who are well versed in the field of paediatric intensive care, and they came up with this, which was published in Intensive Care Medicine in 2017. What it showed is that there was a lot of agreement on some things, but there was a lot of disagreement on many of the other things. So when you've got a patient who first comes in, we're not sure when do we start high flow nasal cannula oxygen, how and when do we then decide to put them on non-invasive? If we do, then move on to ventilation. What mode, what settings, are there any thresholds we need to be examining? How and when do they go on to spontaneous breathing? Is high frequency a good idea? And what are the specific indications for commencing ECMO? And after their discussions, they came with no consensus. Well, when patients are getting worse, I can understand that's actually quite difficult. But what happens when the patient starts to get better? So you can see the patient here starting to get better. They still can't come to a consensus as to how and when the best way to deal with weaning. Fortunately, we've had a couple of trials in the UK, and the advent of spontaneous breathing trials, or SBTs, and trials looking at, should we extubate people to CPAP or should they go to high flow, and all those things they haven't reported yet. But hopefully after they do report, we'll have a better idea as to how things should go, but at least it's a step in the right direction that we're actually looking to get those answers. So while there's no consensus on what the best mode is for pediatrics, the choices that we make on a daily basis are usually based on, one, what ventilator you have available. So if you've got a vent that doesn't do a certain mode, obviously you won't be using it. And as the makes and models get more sophisticated, more modes are available to us. Also depends on the unit and the makeup of the unit. And what you'll find is units that have predominantly pediatrics love pressure, so you'll find a lot of BiPAP. Whereas units which have a bit strong anesthetic influence might like volume a bit more, so you might see a lot of SIMVs or PRVCs which have a volume sort of bias. But overall, most ventilation modes are decided on anecdotal evidence, personal experience, and what the current trends are. So at King's we use the Draeger ventilators predominantly, and Draeger can do all these modes. You'll notice here though we have PCHFO, which you'll find on some of the neonatal ventilators, but you won't find those on the vents on PICU. Important thing to remember though, that from a patient involvement standpoint, there are 3 modes. So as far as the patient's concerned, is the ventilator going to ventilate me and not allow me to have any input? And that's what you find in the control or mandatory mode. So the patient can't trigger a breath, and only useful, and these modes are mainly useful for patients that are muscle relaxed or entirely unconscious and therefore won't be making any contribution. For patients that want to contribute to their ventilation, and we predominantly want all patients to contribute to their ventilation, we have these synchronous style modes, so SIMV, assist control, BiPAP, and etc. And allowing the patient to interact with the ventilator and have some say actually improves ventilator tolerance and can reduce the amount of sedation that you. So these are the primary modes that we use in pediatrics. We don't use the control mandatory modes at all, certainly not at King's. And then when the patient starts to get better, you need to start looking at spontaneous modes. So modes which involve CPAP or pressure support or SIPPV on some of the neonatal ventilators. Now, we shouldn't forget that there are actually new adaptive modes of ventilation which actually know what the end tidal is, know what the SATs are, know what the patient's height and weight, lung characteristics are, and can actually change the patient's ventilation on a breath-by-breath basis. So some of the Elisa and Hamilton ventilators work in this way, basing what it gives to the patient on a mandatory minute volume or a minute volume that it thinks is appropriate for the patient. And as time goes on, we're going to see more and more of those modes creeping into pediatric practice. We commonly use 3 modes. BiPAP because it's nice and patient friendly, SIMV with Autoflow, sometimes known as PRVC on the Siemens Marquet ventilators, and we use as a spontaneous mode CPAP with pressure support. We use primarily the Draeger Infinity V800 ventilator, and this is a screenshot of said ventilator, and here you can see the modes on display. So down the bottom here you can see PC BiPAP, so that's the currently selected mode. We have 4 modes down the bottom, all of which are immediately available. If we require other modes, we have to click on this other modes button there, and then all the rest of the modes are then helpfully displayed. So let's kick off with BiPAP. So BiPAP stands for biphasic positive airway pressure. You set a pressure target, but you effectively set 2 levels of PEEP. So your P-insp, or your inspiratory pressure, is actually a high PEEP setting, and your PEEP is a low PEEP setting, and the patient cycles between the two. The advantage of doing it this way is that the patient can take a breath at any point during the cycle. The inspiration can be ventilator delivered or patient triggered via the use of an inspiratory trigger window, and I'll explain the concept of trigger windows shortly. And expiration is flow cycled via a trigger window. So if we look at the mode slightly more detail, so what you can see is that what you set in BiPAP is FiO2, inspiratory pressure, an I time, respiratory rate, a PEEP, pressure support for the pressure supported breaths, and a slope or a ramp or kind of gradient. So this is how quickly the breath gets to the maximum pressure. So in BiPAP, you'll find that there are both ventilator generated breaths, which last a certain I time, but there are also patient triggered breaths. And the way a patient triggers a breath is that in BiPAP, they will be a mandatory rate. So in this patient, the mandatory rate is 12. So this patient will get 12 breaths a minute. So therefore, for 12 breaths a minute, then this is going to be a 5-second cycle, a 5-second window. So every 5 seconds, the patient is going to get a breath. So the ventilator will give a breath here, but every 5 seconds, it will set up a trigger window. And what happens at this trigger window is that if the patient attempts to take a breath at this point, the breath will be delivered as one of the mandatory breaths and will be counted as one of these 12. Sorry, I'll go back. If the patient attempts to take a breath outside of these trigger windows, what you'll find happens is the patient doesn't get a mandatory breath. Instead, he gets one of these pressure supported breaths. So there are 2 types of breaths happening here, or 3 in fact. You have a ventilator derived mandatory breath, a patient triggered mandatory breath, and a patient triggered pressure support breath. So that's what happens with inspiration. So there are various ways to set the amount of pressure support you get. So this patient is on pressures of 22 on 5. And in this case, what you can see is a pressure support of 16 has been set. So if you add 5 to 16, because pressure support is always above PEEP, this patient will get 22 on 5 for the 12 mandatory breaths, whether they're vent or patient triggered, but will only get 21, adding these 2 together, over 5 for the pressure supported breaths. On the unit, we tend to try and make these 2 the same. So we would normally make sure the pressure supported breath is the same as the mandatory breath, at least to start with. So the mandatory breaths will always be a blue color on the vent, and the pressure supported breaths turn out this nice little gray color, so you can tell when the patient is spontaneously breathing. So that's mostly about inspiration, but there are also expiratory trigger windows. So what happens at the expiratory trigger window is normally you set an I time. So the I time here is 1.6 seconds. So this breath should last 1.6 seconds. However, towards the end of the breath, if the expiratory flow rate drops below a certain percentage, which we set in the background, and it's usually somewhere between 10 and 30%. If the flow rate drops below 10 and 30%, expiration may commence. In such case, the patient doesn't necessarily get the full inspiratory time. Yeah. And the reason that happens is that if the flow characteristics within the thorax, so if the compression and resistance are such that it allows flow to come out quickly, there's no long prolonging the inspiratory phase, or no need in prolonging the expiratory phase. And this looks a little something like that. So the flow rate here is at 100%. If it drops below whatever we've set in the background, so 10 or 30%, then instead of just sleeping down here, the breath is automatically kind of like cut off, and expiration is allowed to commence. So that's what we call flow cycling, and that happens in this BiPAP mode. So the other thing that is good to see in BiPAP is that when you compare a BiPAP breath, when you compare a BiPAP breath here to a standard pressure control breath, what you'll find, because you've set two levels of PEEP rather than inspiration and expiration, the patient can take a breath at any point during the cycle. So if you look here, this is a typical inspiration from a vent, so a mandatory kind of breath, and there's no breathing allowed. In BiPAP, however, the patient can quite happily, merrily breathe in expiration, but it can also take his own breaths while the ventilator is delivering him a mandatory breath. So this allows, well, it helps with tube tolerance, ventilator tolerance, and therefore helps reduce the amount of sedation, and arguably can reduce the amount of time the patient spends on the ventilator and in intensive care. So because of this, a very patient-friendly mode for children, and therefore that's the mode that made this ventilator popular on paediatric intensive care units. So when we start to ventilate patients on BiPAP, this would be the start screen. So let's just remind ourselves of what's going on here. So this is a paediatric patient. You can see that because that icon matches that. We know that this is set up, it's in standby mode, so it's not actually doing anything at the moment, and it tells you that standby patient not ventilated. Patients via ET tube, and you can see that's set there. It's plugged in, and the battery is fully charged. So we know all that now. So it's set to pediatric patient who we've set to 79 centimeters, giving us an ideal body weight of 10 kilos. So that's a bit of a fudge. So if you know the patient's weight, we set the height to match the weight, and it should be the other way around. So this patient is set to BiPAP. And you can tell that the FiO2 there is 21%. It's got a pressures of 15 on 5 with an I time of 0.69 seconds, a respiratory rate of 29. There's no pressure support set. We would normally always set some pressure support once we knew what the pressure we were going to use is. I can tell here that apnea ventilation is on, and I've spoken about apnea ventilation on my additional settings modes, so I won't go into it in any detail here. And here you can see the alarm limits. Now there are additional settings. So if you press this little button here where you've got the three little dots, these are additional or advanced settings that you get in BiPAP mode. So there's a trigger where you set the trigger sensitivity. You can make a decision to set the sigh breath to on or off. Here it's off. Apnea ventilation, I mentioned earlier, is already set to on. So if this patient, if we were weaning the patient and he's on a very low rate, if he stops breathing, he would get a tidal volume of 73 at a rate of 29, and automatic tube compensation is set to off. And again, I've mentioned all these in a previous video. We look at the alarm limits, and basically what you'll find here is that you'll get minute volume and tidal volume alarms, which are very important, as is the apnea time. So if a patient doesn't receive a breath for 15 seconds, the ventilator will cycle into apnea ventilation. So these are all important things that we would check before we started ventilating the patient, and obviously during. So what does it look like when we actually start ventilating the child in BiPAP? So here I've got a 10 kilo 1-year-old child. I've set the pressures up for 15, or with a PIP of 15 and a PEEP of 5. What you note is if you set pressure, as you do with BiPAP, always check the tidal volume. So the tidal volume is here, is 156, which is very high. And you've got a tidal volume to ideal body weight ratio of 16.9. So this obviously means even on these settings of 15/5, which are actually quite modest, this patient is overventilated, and we would need to do something because we're risking lung damage. Now, the reason this happens in life, it doesn't happen to this degree. The reason this is happening, because it's not really, the ventilator is not really attached to a real patient, it's attached to a test lung. So on those pressures, this is the tidal volume that is generated. So if you set pressure, always go back and check the volumes that are being generated. So if you do nothing, what you'll find will happen is that the alarm will start, or the ventilator will start to alarm. So you've got a red alarm because the minute volume is very high, and you've got a yellow alarm because the tidal volume is very high. So obviously when you see those sort of things, don't just adjust the alarm limits, make a decision as to whether something else needs to be done. And in this case, the peak pressure, if this were attached to a real patient, the peak pressure would need to be reduced. Right, moving on to volume control SIMV with Autoflow. So SIMV stands for synchronous intermittent mandatory ventilation, to which we add Autoflow. So this tells us that this breath is a volume controlled breath, so therefore it's a continuous flow breath, because that's how volume is generated. Inspiration can be ventilator or patient triggered, because again there's a trigger window. Expiration is time cycled, so in other words, the patient will get the full inspiratory time. It can't cycle off earlier because there's no flow cycling in this mode. And spontaneous breathing happens in the expiratory phase only, so patient can't have a spontaneous breath during the inspiratory phase, as we saw in BiPAP. Fortunately, pressure support is available for the spontaneous breaths. So this is what this looks like. So with SIMV, with Autoflow, you need to set the FiO2, the tidal volume, the respiratory rate, the PEEP, and if you're going to add pressure support, you would add that too. You set the flow, you set the slope, but with this there's a flow. So the reason there's a flow button here is because we haven't actually switched the Autoflow on. So at the moment, this is just pure SIMV. When you switch Autoflow on, what you'll find happen is this button will disappear. So what's happening in SIMV? So you've set your I time. So the I time here is 1.7, so clearly an adult. And the patient will get a breath which lasts that long. So you can tell that it's a volume style breath because you've got a continuous flow characteristic down here. And this is a pressure supported breath. I explained the trigger windows previously. So for this patient who's got a respirator of 12, every 5 seconds, a trigger window will appear. If the patient attempts to take a breath during that trigger window, which lasts a few hundred milliseconds, then what will happen is that the breath will be triggered and it will be counted as one of the 12. If the patient takes a breath outside that time, he will get a pressure supported breath instead. So that's the basis of SIMV. When you switch on Autoflow, this happens. So you first get a test breath, and you get a test breath which is a volume style breath because it's continuous flow, so the flow is exactly the same. And then after that, it then puts a decelerating flow breath in. Yep, so you can tell that the characteristic of the flow has actually changed. So instead of it being continuous, you get a very fast start, and then afterwards the flow slows down over time. So in other words, to explain what Autoflow is, it's actually a volume targeted breath in a pressure style mode, or a decelerating style mode, and there are a few advantages to doing this. So in other words, the main advantage is actually you'll find that pressure controlled breaths will have a lower peak inspiratory pressure for the same mean airway pressure, so you don't get the high pips that you get in standard volume control if you add Autoflow, and this helps with lung protection. So therefore it's always advisory to add Autoflow if you are volume ventilating. So Autoflow is available for all volume modes on Draeger ventilators. So how do you, these are the settings for SIMV. We've seen them previously, but this is what they would look like for a 10 kilo baby. So you've got tidal volumes which are 73, which is obviously it's about 7 mils per kilo. And you've got a I time which is a lot shorter, and a respiratory rate which is a lot higher. If you want to add Autoflow, what you have to do is go to this button here and then turn Autoflow to on. Now, on all the vents on our unit, if you pick SIMV volume control, Autoflow is automatically set to on, so you don't actually need to go and look for it. But it's a good idea to check, because you'll work on other units where the vents aren't set up in that way. So in SIMV, the things that we have to check are: 1, as additional setting or advanced settings, are 1, Autoflow; 2, sort out the trigger; 3, decide if you want a side breath; 4, to see whether or not you want apnea ventilation on or not, and here you can see it's set to on. And again, automatic tube compensation is set to off. These are the alarms that you get with SIMV with Autoflow. What you'll notice is there's no lower tidal volume alarm, which you get in the pressure modes, and that's because you've actually targeted the volume. So therefore we're not surprised that that isn't there. So what does this look like, or what does SIMV with Autoflow look like in practice? Well, first things to notice is, again, you know Autoflow is on for several reasons. First, you've got a decelerating flow breath on the flow scala. So that tells you that this is actually a pressure style mode, which is actually quite important. So that's the first thing that it will tell you. You can see that the volumes are actually, that has been set, is 100 mils. So this is a 20 kilo child, sorry. It's a 20 kilo child with 100 mil tidal volume. And with that, the peak inspiratory pressure is actually quite high, because the tidal volumes are 5.4 mils per kilo if you're 20 kilos, but you're getting a peak pressure which is quite moderate of 26. Is set to a PEEP of 9, so that tells us that this is a patient who's actually quite tricky to ventilate. The other advantage of Autoflow, obviously, is that the breath is delivered at the lowest possible pressure. So that's the other kind of lung protective mechanism. So when using Autoflow, and we do use it quite frequently these days, make sure that your pressure limit, your upper pressure limit, is engaged appropriately. Right, moving on to spontaneous breathing with spontaneous CPAP pressure support. So this mode is what we use in patients that are spontaneously breathing. So that these are patients that were weaning or have successfully weaned, and what they require is a continuous positive pressure level with the option to add pressure support above the level of PEEP, and we always execute this action. So we always give them a little bit of pressure support to help overcome the resistance in the tube. So when you're setting it, it's relatively simple. So you set the FiO2, your PEEP, whatever pressure support you want, and also there's a slope. I've seen on some ventilators there's a I time max, so you can't actually set the I time with pressure support because the patient determines the I time. However, you can set a maximum I time. So you say, I don't actually want the inspiratory time to go above a certain level, and that is a feature on some ventilators. So this is what it looks like. So you've got your PEEP, and this is your pressure support above PEEP. And again, because it's pressure, this is the pressure scala, so you can tell that the pressure is just constant. You get to there very quickly, and then it drops. And then you've got these nice grey breaths, which tell you that these are patient-triggered breaths. Now, because it's triggered, it's important that you set an appropriate trigger threshold, because if the threshold is too high, and the patient is actually trying to take a breath, he's not actually going to get any of these breaths. So you have to make particular attention, or pay particular attention to the trigger threshold. So this is what it looks like on our vents. So you've got those same four modalities I mentioned earlier down the bottom. And this is where you would assess your trigger ventilation. So for most pediatric patients, you get a trigger value of 1. I think for neonates, it's about 0.4. And for adults can be 1 to 2. But that needs to be set appropriately. Otherwise, the patient will be fighting to get the support that we're hoping to give them. Right. So we use it on almost every patient. So almost every patient gets a spontaneous breathing trial before we try to extubate them. And this is what it would look like in real life. So you can see that these are spontaneous, these are patient triggered breaths, because these little lungs you see here correspond to the patient attempting to take a breath. If we're going to use this mode long term, it's actually, and if you're going to use it long term and the patients have relatively small tidal volume, it's sometimes worth adding in a sigh breath, or perhaps trying out variable pressure support. Now, variable pressure support and smart care are two kind of like modalities on Draeger ventilators that we haven't started using. Smart care requires you to pass the end tidal and saturations through the ventilator, and then the ventilator decides how much breathing or what size of breaths or what tidal volumes the patient requires. And since we haven't got that facility on our ventilators, we can't use them, but we could use variable pressure support. So variable pressure support takes into consideration that in life and in nature, no one takes the same size breath every time. But if you're on pressure support ventilation, you do. So this is about allowing the amount of pressure to vary over time, and you set the amount of variance you're prepared to have. So those are the modes we use at King's. There are other modes, as I've demonstrated previously. The ones that are probably worth a mention is down here. There's one called volume control mandatory minute volume, and that just bases the patient's entire ventilation on a minute volume, and if the ventilator will predict if the patient's going to achieve that minute volume, and if it is, it adds very little, so supports minimally. But if the patient is not going to, it's clearly not going to achieve it, then the patient then chips in a lot more frequently. So that's something that we could be looking at in the future. The other thing that we should look at, obviously, is this one, which is pressure control APRV. So with the COVID pandemic, sort of lung disease adults and children are turning up with, are actually quite difficult to ventilate and oxygenate, and APRV would be an excellent mode to achieve adequate oxygenation. So it's something that we should consider. I won't be discussing it any further here. Right, so that's all I've got for you this time with this one. Things we've looked at is issues surrounding nomenclature. We've looked at the makeup of the mode, and we've examined the 3 most commonly used modes at King's. I haven't told you which mode I think is best for which disease process or patient category, but I think it's something that you should take this information that you've just gleaned and go away and think about. So thank you for staying till the end. Next video will be on ventilating the normal lung. Thank you very much. Bye.